Hello, my name is Agnes Montgomery and I will be presenting this case report. In children, pulmonary calcifications may be completely asymptomatic and found incidentally. The etiology of pulmonary calcifications includes infections, granulomatous diseases, and other significant pulmonary and systemic pathologies. Therefore, the presence of pulmonary calcifications, whether symptomatic or not, should never be dismissed as insignificant without ascertaining their etiology. A high index of suspicion for serious underlying lung disease is essential to making an appropriate, timely, and potentially life-saving diagnosis. In this case, a 5-year-old male was admitted to the general pediatric service with respiratory distress in the setting of diffuse expiratory wheezing and croup-like cough. His physical examination was otherwise unremarkable. Chest X-ray demonstrated radiodensities in the right lung apex and the left hilum. Pulmonary consultation was requested. The patient was born full term, and his growth and development were normal for age. He was well until approximately 6 months of age, with onset of recurrent skin and respiratory infections that were sometimes treated with antibiotics. At about 4 years of age, he was diagnosed with periodic fever, aphthous stomatitis, pharyngitis, adenitis, also known as PFAPA syndrome, due to multiple episodes of fevers, rashes, sore throat, oral ulcers, and lymphadenopathy that resolved after TNA. At 5, he required circumcision due to recurrent infections and ulcerations of the foreskin. Later, recurrent croup and asthma were diagnosed due to episodes of stridor and cough, respectively. He was treated with albuterol as needed, though without significant improvement. His family history was significant for autoimmune diseases in multiple family members. Non-contrast chest CT revealed calcified left hilar lymph nodes, largest measuring 1.9 by 1.3 centimeters, and coarsely calcified fibronodular densities in the right upper lobe. Initial lab workup, as detailed in the slide, was unremarkable, and infectious workup was significant for positive strongyloides IgG. Neutrophil oxidative burst index was low, and genetic testing confirmed X-linked chronic granulomatous disease with homozygous mutation in the CYBB gene. Evaluation of the airway with rigid and flexible bronchoscopy was unremarkable. BAL yielded neutrophil predominance with mixed anaerobic flora that was treated with amoxicillin clavulanate. He was started on prophylactic trimethoprim-sulfamethoxazole and itraconazole. CGD is an inherited immunodeficiency characterized by an increased susceptibility to infections caused by bacteria and fungi and subsequent granuloma formation. Our patient's history of recurrent aphthous ulcerations and skin infections was misdiagnosed as PFAPA syndrome, with pulmonary calcifications providing the clue for an alternate and very differently managed diagnosis. He will continue to undergo routine lifelong monitoring for infections and inflammatory manifestations to include obstructing granulomas. Aggressive treatment of known infections has been shown to reduce the morbidity of this life-threatening diagnosis. Thank you for your attention.